much for inviting me to give this talk, especially thanks to Saravana to give me the opportunity. So I'll be talking about cerebrovascular activity and how we can measure that using both functional MRI. So the first two questions that arise is, why would we even measure cerebrovascular reactivity, or CVR as we would abbreviate it, and why would we measure CVR then with both functional MRI? So cerebrovascular reactivity allows you to provide a hemodynamic stress test for the brain, and I've given you a schematic here with the parameters we kind of familiar with, where we can kind of image or test the hemodynamics in the brain. For instance, cerebral blood flow, cerebral blood volume, oxygen extraction fraction, the CMRO2, and also the CVR. And what's interesting in the CVR is that if you look at hemodynamic failure or too little blood flow to the brain, it's a parameter that decreasingly gets worse according to the vascular pathology or the autoregulatory failure. For instance, if we have a look at cerebral blood flow, this may be normal even if there's a vascular pathology present. So baseline blood flow may be okay, but it's not what we're interested in. We would like to know what is the consequence if we stress the brain, for instance, with Diamox or with a carbon dioxide challenge. And what you see then is that, for instance, CVR or cerebral blood flow go down if you challenge it. CVR in that regard may also be a bit more sensitive than oxygen extraction fraction, since this parameter may be biphasic and at the end of the autoregulatory reserve. So it's the exhaustion of autoregulation. It may increase first, but even in worst case scenarios, it may also go down. So you have a paradoxical normalization or lowering of the oxygen extraction fraction, despite being littler blood flow. So that's why CVR could be a very good test. And just to give you an example, between baseline blood flow measurements and stress test blood flow measurements, this is a water PET. If you look at the baseline, the top figure, you see that the hemodynamics are somewhat normal. So the baseline blood flow in a given patient with a cerebrovascular disease may be normal. But if you then give Diamox, so you kind of give a reaction to the brain, cerebrovascular reactivity or perfusion reserve, whatever you want to call it, it's all the same at the end. You see that after Diamox, after the brain is stressed, you see in the right hemisphere that is hyperperfusion, so hemodynamic failure. This is what we're very interested in, because this shows us whether a patient is at risk for brain pathology, and especially for recurrent ischemic stroke. This is where CVR has given a lot of merit, and is a very important marker that if you know that the CVR is impaired, there could be a higher risk of recurrent ischemic stroke in patients with cerebrovascular disease. It may also lead to impaired neurocognitive performance. This is a quite new topic of a lot of interest in the last couple of years, and there's increasing publication actually showing that this also with impaired CVR present, the neurocognition may also be declining. Thirdly, a little bit less known, I think, but also very interesting, is the chronic ischemia. So we have patients that have impaired CVR, not really had a stroke. However, they also show consequences to the brain. For instance, cortical thinning. This is something we published in our group, and I'll show you some data of that after. So this is why, in general, these are just like three mentions, but this is why we would measure CVR in a patient with cerebrovascular steno-occlusive disease. So why then measure it with blood oxygenation level-dependent MRI? Well, we know that the nuclear imaging techniques available, like PET or SPECT, even xenon CT, are very good in looking at autoregulation or perfusion reserve or cerebrovascular reactivity. However, they are not available in every hospital. They're quite expensive techniques and very limited in use. That's why not very generalizable for clinical routine imaging. That's why a lot of MRI techniques have been developed. The most two popular ones, I would say, most well-known ones are the arterial spin labeling, ASL MRI, or the BOLD MRI. And since they're MRI-based techniques, they also have the potential to become clinical imaging techniques. I just mentioned two disadvantages potentially of these techniques. I think for ASL, the arterial spin labeling, although it can very nicely and without contrast measure direct blood flow changes, so CBF changes, it has a lower signal to noise for the imaging compared to bolts, and in my experience, and you may challenge me on that, is that it's not reliable for bilateral disease. So if you employ it for moya disease, for instance, which is typically a bilateral disease, you don't have a normal CBF input, so you don't really know what the blood flow delay to the brain is, and this is why ASL may not perform as reliably as, for instance, PET or SPECT in that regard. For bolts, we chose it since it has a high imaging spatial resolution, and it could be repeated quite easily. I mean, it's a highly repetitive scan. It is, however, not a direct CBF, cerebral blood flow measurement. This is the major disadvantage of bolts, so to speak. So how do we know blood oxygenation level dependent MRI? Well, it's mostly known in neuroscience. It all depends on the bolt contrast, which is the paramagnetic properties, meaning more deoxyhemoglobin in the brain gives a lower signal, and the classic neuroscience application would be to look for eloquent brain areas, also for brain tumor surgery, for instance. So finger tapping, speech, because this draws on the ability of the brain, the unique ability to have a focal increase in blood flow due to the autoregulation demand. So if you do finger tapping, you would see a very nice signal because there's increased blood flow, increased neuron activity, the neuroscientists would say, in the precentral gyrus of the hand area, so to speak. But the same contrast concept is true if you give a generalized vasoactive stimulus like carbon dioxide or Diamox, for instance, is that the entire autoregulation in the brain responds. You have a maximal vasodilatation in the brain, and you get increased blood flow everywhere in the brain. Again, this is the idea. Bolts does not measure CBF directly, but the increase in signal would be a surrogate theoretically for increased blood flow. And then you get a map like this. You have the entire signal in the brain, and then you can measure where the blood flow would be accurate, or the cerebrovascular reactivity, obviously, and where it would not be accurate. And you can color code that. So this is the concept in a nutshell of bolt MRI using CO2 to measure cerebrovascular reactivity. And then you can map it for the entire brain. So this movie shows you the bolt scan in the patient with carotid occlusion on the right side. Normal CVR, so normal reactivity would be red, abnormal would be blue, and you see the right hemisphere in this symptomatic patient with carotid occlusion on the right side shows exhausted cerebrovascular reactivity, so impaired cerebrovascular reactivity on the right side. This is the mapping of the bolt with CO2. And the unique ability of the CO2 is not that we just give CO2, let patients inhale it, but we also control it very strictly. So the red line here is the CO2, where you can see that the CO2 is held normal. It goes down, so we do hypocapnia and then hypercapnia, so high CO2. And then you see in like a healthy voxel, the red one, you see that the bolt signal very nicely follows the response. So you get a vasoconstriction at hypocapnia, vasodilatation at hypercapnia. So the vasoreactivity would be normal here. If we go to a blue voxel, so a voxel where we know it's impaired reactivity, you see that the paradoxical response happens. So if you have vasodilatation, the area that is affected by the vascular pathology shows actually a decrease in bolt signal, so arguably a decrease in cerebral blood flow. Obviously, as I said, it's not a direct CBF measurement. That's why we compared our bolt CVR or validated against water PET. So Diamox challenged 15.0 labeled water PET. And what we saw actually is that the performance of the bolt CVR here in black is quite similar to the PET. And we actually have a very good agreement. So we can actually say that bolt CVR could be a surrogate measure for cerebral blood flow changes in patients with cerebrovascular disease. So what are the potential clinical applications then? Well, as I mentioned before, the risk assessment of recurrent ischemic stroke would be the most important one. This has the most clinical relevance for symptomatic patients with stent occlusion, so with stent occlusive cerebrovascular disease. It could also be a very good tool because if you can bring it to the clinical setting, you can also scan patients or select them for revascularization. It could be endovascular, it could be microneurosurgical, and also follow up, because you can then do sequential follow-ups. And more like touching a bit on the science, I guess, but also still for clinics, it's the assessment of the chronic ischemia, where I would really look at brain effects of the brain areas that are exhibiting the cerebrovascular reactivity impairment, whether there's cortical thinning present or actually whether it has an effect on the neurocognition. And I'll just give you per item a small example of the data we gathered in this regard. So for both CVR, because we have a standardized CO2 stimulus, we can also quantify our CVR response. And we found that the bold single change per millimeter CO2 response larger as 0.1, that is the quantitative cutoff we found, would be patients that have not impaired CVR, and smaller than 0.1 would have impaired CVR. And if you compare these two patients, so the ones with less than 0.1 bold CVR response, the impaired CVR ones, compared to the patients with normal CVR response, you see that there's a hazard ratio of 11. So there's 11 times higher risk for patients exhibiting impaired CVR with symptomatic stent-occlusive cerebrovascular disease to have a recurrent stroke within a year. I mean, the cutoff would be about a year. The most dramatic effect is within the first year. But you see there's a very big change, and this is very relevant because now we have a number potentially to apply in the clinics. This data is unpublished. I just want to show you because I think this is very exciting to kind of make a translation of a new technique into the clinical setting. So for revascularization, I just chose an ECIC bypass flow augmentation procedure, being a cerebrovascular neurosurgeon. But again, it could also be for an endovascular means and also for acute stroke. This is also the advantage of an MRI technique. You could apply it in acute stroke potentially. So this would be a patient with chronic right-sided ICA occlusion. The pre-bypass full CVR scan showed a large right hemispheric impaired CVR, so the blue area again, we have to focus on. Because he had a fetal PCA, you also see that the entire hemisphere is actually blue. So this patient received an STA-MCA bypass on the right side, and after 12 months, the patient was asymptomatic. We had this bold CVR scan where you see quite a good normalization of the CVR. It gets into the yellow-red area again, which would be normal cerebrovascular reactivity response. The white matter is for every stent-occlusive patient seems to always lag behind. This is mostly because of the small end arteries, the less collaterals available. This would be still interpreted as a normal post-op scan. But this is also the nice thing, as I said, for a clinical bold CVR, since you can now do sequential follow-ups. You could also do it every 6 months. It's not a technique that is not available in the clinical setting. This I just chose 1 year because it would be our follow-up standard operating procedure or workflow here at the University of Zurich. So again, going a bit more towards like the neuroscience versus clinics. So does the revascularization really has an effect on cortical thinning? So what we found, and this is a publication we had like 10 years ago or 12 years ago, is that patients with chronic ischemia, so patients that were symptomatic or not, but had like blue area, meaning like an area in the brain with impaired cerebrovascular reactivity, however, without any morphological tissue loss. So there was some flare. They all had a normal flare, all these patients. These were 20 patients we studied, so with present impaired CVR on one hemisphere and no signs of stroke on flare or DWI. There was just normal brain tissue. We found that these areas, so the cortex in this area was 8% thinner as compared to their area contralaterally that had normal cerebrovascular reactivity. So this was an interesting finding in terms of the consequence of a chronic ischemic patient. And interestingly enough, those patients that we then revascularized, since they had this impaired CVR, we showed that those patients that had successful revascularization, so with normalization of the CVR after 1 year, as I showed you in the previous slide, actually the cortical thinning went up again. So it kind of seemed to be a reversible process where the neurons would regenerate or at least maybe do a new sprouting or whatever would happen. We don't know what happens, but we saw that the phenomenon of cortical thinning could be reversed by restoration of blood flow in this area. And of note, and this what made our findings a bit more robust, is that the patient that received a bypass, but where the bypass occluded or was not successful in providing enough blood flow, so meaning the patient still had impaired CVR postoperatively, is that the cortical thinning was progressive. It went further. And this concept is also interesting in the light of like normal healthy. So when we first started doing this bold CVR technique at the University of Toronto, this was around 2005, So about 20 years ago, almost, we just first started with healthy subjects. These were people like you and me, between 20 and 40 years of age, no brain pathology present. We just did a bold CVR scan. What we saw in 30 patients that we accumulated the maps of is that the reactivity would be normal everywhere as expected. However, in the deep white matter, you already saw the impaired cerebrovascular reactivity. And these are completely normal, healthy people, but you already saw that the impaired reactivity in the deep white matter is already present. And this was a very surprising finding at the time, obviously, but also interesting, because when we then compared it to an independent publication, this is looked at heat maps, so prevalence maps of leukoariosis over a lifetime. It was an independent publication by SECDEF in 2007. You see that these heat maps obviously would appear in the deep white matter, but also correlate very well where we already find this impaired CVR maps. So that's why this whole concept of chronic ischemia with cortical thinning, with already impaired CVR present in us all in the deep white matter, that may be translatable to this neurocognitive decline that we kind of hypothesize now with impaired CVR, where the books are still not closed. It's still an active research area, but this is, again, providing functional data, so cerebrovascular activity data with morphological data, leukoariosis onset over lifetime or cortical thinning, where we may provide an extra piece of the puzzle to this phenomenon. So I hope I could give you a little bit of a brief overview of how bold CVR could be mapped, how could it be done, and what the clinical relevance could be. So I thank you very much for your attention.